going to be giving the next lecture titled Controlling Gastrointestinal Symptoms in Cancer Patients. Is no less a person than Dr. Kyriakos Stylianides. Dr. Stylianides has been practicing palliative care in Cyprus since the year 2006. He graduated from Ovidius Medical University of Constanta in Romania in 1999. From 2000 to 2001, he worked as a junior doctor in the Bank of Cyprus Oncology Center in Nicosia. And during his time there, he did several courses in palliative care, including Essentials in Palliative Care from Prince Alice Hospice, Communication Skills course, and 2 months fellowship in San Diego Hospice. From 2015 to 2017, he studied for a postgraduate degree in hospital management at the Open University of Cyprus, and in November 2017 was awarded the Bachelor degree of Health Units Management. Since November 2018, Dr. Stylianides has been employed at the Pan-Cyprian Association of Cancer Patients and Friends as the medical director. In March 2019, he spent a month in Ohio State, where he was trained in palliative care for children. And since September 2022, Eden Hospice in Lannis and St. Michael's Hospice in Paphos started. He has been providing services for palliative care patients through Cyprus National Health System. And he directs both hospices. He lectures 6th-year medical students in palliative care at the Cyprus Medical School. He participates with ASCO as a facilitator in education for palliative care around the world. He has participated in several master classes for palliative care, both in organizing the master class and as a key presenter and facilitator. Dr. Stylianides played an important role in establishing legislation for palliative care in the island of Cyprus. He convinced the Ministry of Health that palliative care should be part of the national health system, and it should be offered to both adults and children from the beginning of their diagnosis. His main goal was to make palliative care available for all the patients that needed it all over Cyprus. Dr. Stylianides is the first doctor registered as a palliative care physician in Cyprus National Health System. Please join me in welcoming Dr. Kyriakos Stylianides to present to us his lecture on controlling gastrointestinal symptoms in cancer patients. Welcome.
Thank you again, Kenneth. Such a common problem, the gastrointestinal symptoms in cancer patients, and it's a problem that we have to face very often. And I hope with this presentation, it will help to control as much as possible the symptoms of our patients. So first of all, I would like to thank you, the PCIC, and Dr. Frank Ferris for providing the slides for this presentation. And I will start with nausea and vomiting, which is the most common and quite often difficult to control.
But I could not have imagined the depths of humiliation. Oh, oh, God, please. Oh, oh, oh. Steady, steady. Oh God. Oh. What's left? I haven't eaten in 2 days. What's left to puke? You may remark that my vocabulary has taken a turn for the Anglo-Saxon. God, I'm going to bath my brains out.
How does it feel to spend the whole day like this? It must be awful. The objective is to describe the pathophysiology of nausea and vomiting. We have to develop a rational approach to management, and of course, practice makes perfect. Why do we care about nausea and vomiting? It's a very common symptom with cancer patients. It causes distress both to patients and their families, and of course to health care providers. And it affects the quality of our life. What is the assessment? Location, description, how does it change over time, the severity, and of course the effect of medications and other therapies. And how do we manage it? We identify the cause or the pathway, and we either treat the cause or we block the pathway. What are the main causes? We have divided the main causes of nausea and vomiting into 3 categories: above the neck, below the neck, and the systemic. Where above the neck is a mass, a metastasis, the meningeal irritation, migraine and other headaches, and movement. Below the neck, again, it's a metastasis or a mass, motility, mucosal irritation, mechanical obstruction, myocardial infarction, and maternity. And systemic is mentation, anxiety, medications that they cause nausea, vomiting, microbes, infections, and metabolic. And that's another acronym of vomiting, where V stands for vertigo-vestibular, O for obstruction, constipation, M for motility dysfunction, I for inflammation of gut, T for toxins, I for intracranial masses, N for nerves and anxiety, and G for gums, mouth, and oropharynx. What are the pathways? 2 common pathways. One is the chemoreceptor trigger zone that is triggered, and then it's the vomiting center that is triggered. And the stimulating pathways are the chemoreceptor trigger zone, the cortex, the vestibular, and the peripheral, which is the gastrointestinal tract. The neuroreceptors involved in triggering nausea and vomiting are neurokinin, serotonin, dopamine, acetylcholine, histamine, and GABA. And this is a nice diagram where each chemoreceptor trigger zone is each neurotransmitter is involved in which area. And we need a rational approach to management. As we said, we have to identify the cause and the pathway. We dose around the clock. We titrate to effect. We consider side effects of our treatment. And if first agent is ineffective, add another with a different mechanism of action. And we have to consider also non-pharmacological management, like cognitive behavioral therapy, acupuncture, relaxation, and hypnosis. Avoid strong smells, eat small and frequent meals, and supplements like ginger. Medication classes that are used are the dopamine antagonists, 5-HT3 antagonists, NK antagonists, prokinetics, antihistamine, anticholinergic, steroids, and benzodiazepines. And of course, practice always makes perfect. Here, I providing you with 3 slides, 4, which they summarize the nausea management. First, this is the causes and what kind of medication we can use to treat the cause of nausea and vomiting, which are also available to you, and you can use them. And these are the usual doses of the different medicine that we use in order to control nausea and vomiting. So, as we said, it's a rational approach to manage nausea and vomiting, understand and target the cause and/or pathway. Let's move to constipation and malignant bowel obstruction, which is also a very common problem in cancer patients. And unfortunately, it's usually severe with a lot of side effects. Is usually for patients with advanced illness. We need to describe the causes of constipation, compare and control laxatives used for the treatment of constipation, and outline an approach to manage constipation. When we have a normal bowel movement, it means that there is a normal lubrication and motility. So solid waste and water content are in a balance, and then this can be excreted normally through the intestine. And constipation, when it occurs, it's a persistent, difficult, infrequent, or seemingly incomplete defecation. And it's also, as I said, a very common symptom we see in our patients, and it causes a lot of problems, and it destroys the quality of their life. It leads to decline functional status, decline nutritional intake and socialization, poor quality of life, and of course it hurts. There are many causes of constipation, from surgery to trauma, peritonitis, pregnancy, diet low in fiber, dehydration, psychogenic, painful fissures or hemorrhoids, and mechanical obstruction. The assessment of for constipation, we need to get a good history, the quality of bowel movements, any other associated symptoms, any prior surgeries, medications used, and advanced illnesses like heart failure and of course cancer. Examine the patient, very important, and consider testing for electrolyte abnormalities and imaging. Management of constipation should be done as soon as possible. Prevention is the best treatment as always. So we have to start by preventing constipation. In order to prevent it, we need to assess for the cause, treat the underlying cause, and then treat the symptom. Medications that very often cause constipation, first of all, analgesics and opioids. Our colleague before, she mentioned that very often, almost always, opioids, they cause constipation. And as we say, the same hand who prescribed opioids needs to prescribe laxatives at the same time. And of course, other medicines causing constipations like anticholinergics, calcium channel antagonists, diuretics, iron preparations, polystyrene sodium sulfonate, barium sulfate, antacids, clonidine, ganglionic blockers, muscle blockers, and ondansetron. Goals for management, often resetting expectations, balance stool frequency and consistency with comfort and always dignity. Incorporate individual preferences. It's all about the patient. Each patient has its own needs. Contributors to constipation. If any of these solid waste, lubrication, water content, or motility, it's not balanced, we'll get constipation. So we need, for normal bowel movement, we need to balance these four. There are non-pharmacological treatments for constipation, like fiber-rich foods, increased physical activity, increased fluid intake, and ritualized bowel habits. And of course, we can use pharmacologic treatments like bulk-forming laxatives, surfactants that are actually softeners, osmotic agents, stimulant laxatives, and opioid-induced constipation agents that they reverse the opioid cause of constipation. Here are some medicine used in order to control constipation. And it's important to see where we are targeting, and never be afraid to use an enema if all the others, they will not work. The sites of action of common anti-constipation agents. So for the small bowel, it's castor oil, polyethylene, glycol, lubiprostone, and linaclotide. And for the colon, bisacodyl, senna, lactulose, and hyperosmolar salts. We use a stepwise approach to managing constipation. Step 1, provide patient education, increase fiber and fluid intake, encourage mobility. Step 2, modify risk factors, reduce or eliminate any constipating medications. And treatment for mild symptoms, stop ineffective treatment, start polyethylene glycol, and start senna orally. The step 2 is increase the dose until resolution or maximum dose is achieved. And if we have loose stools, we decrease the dose by 50%. For severe refractory symptoms, we might need to do an abdominal X-ray or CT scan, or even a colonoscopy and anorectal manometry. We use stronger agents like magnesium citrate and bisacodyl. And step 3, if none of the first 2 steps are working, we can use enemas. In case of opioid-induced constipation, opioids, as you know, they attach to mu receptors in the small intestine. This inhibits the release of neurotransmitters such as acetylcholine and interrupts normal peristalsis. This decreases the intestinal secretions, and there is an increase of fluid and electrolyte absorption, which in turn they make the stools hard and nowhere to defecate. And of course, if which they do cause increased anasphycter tone, you don't feel that you want to go to defecate. And constipation, it's one of the common causes of delirium, which is another symptom very difficult to manage. Prevention for opioid-induced constipation is very important, as we said. All patients should be prescribed a laxative like Senna that they are on opioids. It's not correct to rotate the opioid because of constipation, because they will also cause constipation. So the first line is stimulant laxatives, but if they are not working, we can use peripheral opioid mu receptor antagonists like methyl naltrexone and naloxegol. Very expensive medicine, not always available. That's why it's very important to control constipation, to prevent constipation induced by opioid use. Special considerations for palliative patients: if there is an obstructive mass or carcinomatosis, which can be the end of the cause of constipation. Ileus, very common in our patients with cancer. And we have to consider if they are end of life and how we will treat those patients. And we have to consider if they are neutropenic. Often our patients, they are on antineoplastic treatment with chemotherapy and they are neutropenic. And also consider overflow incontinence, because they might have an obstruction, they get diarrhea, but this is diarrhea, as we call it, an overflow diarrhea, and the intestine is still obstructed. Docusate is rarely sufficient and often unnecessary. Think mush and push. So we want to make them, to soften them and make the intestine to increase the peristalsis in order to for our patient to defecate. Maximize adjuvant pain medication, and we should always aggressively manage constipation. I'm providing you here an assessment of constipation and management of constipation with all the medicine and the causes of constipation. As we said, a rational approach to managing constipation: understand and choose medication based on the pathophysiology. And the last topic, it's bowel obstruction, one of the most severe symptom that we need to address for patients, especially with advanced metastatic cancer. Very common, and a symptom that causes a lot of dysfunction to the patient. The background, so is usually caused by ineffective motility or occlusion of the lumen, common affiliated cancers, large or small bowel. It can be partial or complete obstruction, and its relevance to palliative care. Because life expectancy in inoperable, if we can operate, it's 4 to 6 months, but if you cannot operate, it's 4 to 6 weeks. This is usually the case. We have a patient with ovarian cancer with a continuous and colicky abdominal pain, abdominal distension, no bowel movement for 7 days, nausea and vomiting. It's acute, large volume with undigested food, and is usually there is relief after emesis. The treatment, if we can reverse it means it's a good prognosis. We try if we can non-surgical for partial or complete obstruction. The management algorithm, if we have a malignant bowel obstruction, if there is too much vomiting and if the patient can tolerate, we have to use an NG tube and haloperidol. And then the plan is according to the prognosis of each patient. If it's years, then yes, he needs surgery and support with maybe parenteral nutrition. But if it's days to a few weeks, then we take supportive measures using pharmacology and a venting G-tube to relieve the symptoms if we fail to manage the obstruction with medical management. So that the patient can have some taste of food. Stents are used, surgery, as we said, and some decompressive interventions. Always it has to do with life expectation of patient, of each patient. So it's very important to assess the patient and to address the prognosis of our patient. Unfortunately, when we have a complete bowel obstruction, it's a vicious circle where this bowel distension, bowel contractions are increased, there is continuous abdominal pain, there is damage of intestinal epithelium and hypertensive state in the lumen. There is an inflammatory response with production of prostaglandins and secretagogues, VIPs, and nociceptive mediators, which leads to hyperemia and edema in the intestinal wall. This increases in the bowel secretion of water, sodium and chloride, which can lead to nausea and vomiting, and increases the gut epithelial area, surface area, increase more the lumen contents, and then this is like a vicious circle, which is getting worse and worse until we can find a way to resolve it. And we can consider a progenetic only if there is a partial obstruction, because if there is a complete obstruction, nothing can help. And in this case, if there is a complete obstruction, we have to consider an anti-secretory. And if there is nausea and vomiting, an antiemetic. Steroids are helping for the inflammation. And of course, for the pain, we use analgesics. We have to, If there is a partial malignant bowel obstruction, we have to try and get the bowels moving. We don't need to use an antisecretory. We consider a laxative, a question for the progenetic, if it's not a complete obstruction, dexamethasone for the inflammation. Opioids can be used if we cannot control the pain otherwise. The treatment goal, if we have a complete bowel obstruction, is where the gut shut down completely. At this point, we need to use, in addition to dexamethasone and opioids, an antisecretory, and for nausea, we use haloperidol. And as I said, we can consider using a ventigastrostomy. This is the usual case, young female with cervical cancer and peritoneal carcinomatosis. It's a complete bowel obstruction. So she has nausea, vomiting, and pain. And we can administer all this medication together, like metoclopramide, dexamethasone, haloperidol, and octreotide, together with hydration. And in palliative care, we do not use IV, we use subcutaneously. Most of these patients, they do not have IV access. They have lost a lot of weight, they are dehydrated. So we use subcutaneous access, and we can administer all this medicine over 24 hours because we always act according to the pharmacokinetics, and they need a continuous infusion of this medicine to control their symptoms. And as I said, we always consider about pain, and the use of opioids and anticholinergics can help to relieve the pain. These are some of the doses that we can use for the malignant bowel obstruction. In summary, a rational approach to managing constipation and malignant bowel obstruction, we have to understand and choose medication based on the pathophysiology. We don't want to see these pictures in front of us. And as Gandhi said, you need to be the change you want to see in the world. So act fast, relieve the symptoms, and never allow our patients to suffer alone. Thank you very much for your attention.